Hey everyone, and welcome to this high-energy explainer. Today, we're going to master the absolute need-to-know facts of acute respiratory failure for your NCLEX and Med-Surg exams. We're breaking down exactly what you need to look for at the bedside, the specific numbers you absolutely have to memorize, and the crucial interventions that will literally save your patient's life. Picture this for a second. You walk into your patient's room, and the numbers on the monitor are telling the story before the patient even has the chance to speak. Oxygenation is crashing and carbon dioxide is climbing. This is acute respiratory failure happening in real time. The body is desperately fighting to breathe, and as the nurse, you are the first line of defense.
Section 1. Diagnose the gas exchange crisis. So at its core, acute respiratory failure is simply the lungs' inability to maintain adequate gas exchange. It's really the final common pathway for a whole host of respiratory emergencies. To master this, you need to split respiratory failure into two distinct buckets. First up is type 1, or hypoxemic failure. This is strictly an oxygenation problem, where oxygen just cannot get into the bloodstream. Think ARDs or pulmonary edema, where fluid is basically blocking that transfer. Second is type 2, or hypercapnic failure. Now this is a ventilation problem. Air isn't moving in and out effectively, so that toxic CO2 can't escape. This is what you see with COPD, asthma, or an opioid overdose that's suppressing the drive to breathe.
Now you definitely want to pay attention to the arterial blood gas, or ABG criteria that separate these two types of failure, because the NCLEX absolutely loves to test these numbers. For type 1 hypoxemic failure, you're looking for a PaO2 of less than 60 millimeters of mercury. That is your defining marker. For type 2 hypercapnic failure, you're looking for a PaCO2 greater than 50 millimeters of mercury, but it's paired with an acidic pH of less than 7.35. These numbers right here, they define the crisis.
Section 2. Recognize, spotting the signs early. Because remember, we don't just treat monitors, we treat patients. So what are you actually going to see?
All right, this brings us to a massive must-know concept. When a patient is starved for oxygen, the brain is the very first organ to complain. Our early signs of hypoxia form the acronym RAT: restless, anxious, and tachycardic. You might also notice confusion and a fast respiratory rate, or tachypnea, as the body frantically tries to compensate. Listen, if your patient suddenly can't get comfortable, seems unusually anxious, or is acting a little confused, you need to act right now. The brain is literally sending out an early warning signal that it lacks oxygen.
But what happens if we miss those early RAT signs? Well, we rapidly progress to the late ominous signs, which we remember with the acronym BED: bradycardia, extreme restlessness, and a dusky appearance, which is cyanosis. You might also see lethargy progressing into a coma, with breathing becoming slow, shallow, or completely absent. I can't stress this enough. Cyanosis is a late sign. If your patient's lips and fingers are turning blue, they are on the absolute brink of cardiopulmonary arrest.
Check out this crucial NCLEX trap. A restless, agitated, or anxious patient might actually be hypoxic. If you mistakenly assume they're just having behavioral agitation and you give them a sedative without assessing their oxygenation first, there's a real chance you could suppress their breathing entirely and cause a fatal respiratory arrest. Always treat the brain's first warning with oxygen, not sedation.
Section 3. Intervene. Priority nursing management. Okay, so we've spotted the signs. How do we fix it?
We're always going to fall back on our ABCs. Priority number 1 is airway. A patent airway precedes absolutely everything else. Open it up, suction if you need to, and sit that patient up in a high Fowler's position immediately. Number 2 is breathing and oxygen. Deliver supplemental oxygen to correct that hypoxemia right away. And number 3 is support ventilation. Depending on how bad things are, this might mean non-invasive support like BiPAP or CPAP. Or if the patient is actively decompensating, you're preparing for immediate intubation and mechanical ventilation. But here's the thing, oxygen alone isn't a cure. Priority number 4 is treating the underlying cause. Gas exchange just isn't going to recover until the driver of the failure is fixed. So that means administering bronchodilators for asthma or COPD, antibiotics for pneumonia, or naloxone for an opioid overdose. And finally, priority number 5 is continuous monitoring. You've got to keep a close eye on those ABGs, pulse oximetry, and their level of consciousness so you can catch any further decompensation early. Real quick, before we test your knowledge, I want to highlight a high-yield pearl that shows up constantly on exams. Using non-invasive ventilation, specifically BiPAP, is a critical early intervention that can effectively reverse hypercapnic failure. For a patient with severe COPD who's retaining a ton of CO2, putting them on a BiPAP machine early can blow off that excess carbon dioxide and completely prevent the need for intubation. It is a total game changer.
Section 4. Test yourself. NCLEX prep. We've covered the patho, the numbers, the early warning signs, and the critical nursing actions. Let's lock this all in with some active recall.
Question 1. An early sign of hypoxia in a client with developing respiratory failure is A. Cyanosis, B. Restlessness and confusion, C. Bradycardia, or D. Decreased respiratory rate. Drop your answer right down in the comments. You've got 3 seconds to lock it in. 3, 2, 1.
And the correct answer is B. Restlessness, anxiety, and confusion. Remember our memory trick from earlier? RAT for the early signs and BED for the late ones. Restlessness is the brain crying out for oxygen. Cyanosis and bradycardia are those very late, ominous findings that tell you your patient is about to code.
Okay, let's try a slightly more advanced one, focused on ABG interpretation. Question 2. An ABG shows a PaO2 of 55, a PaCO2 of 58, and a pH of 7.28. Does this indicate A. Normal gas exchange, B. Metabolic alkalosis, C. Acute respiratory failure with hypercapnia and acidosis, or D. Compensated respiratory alkalosis? 3, 2, 1.
Nailed it. The correct answer is C. Let's do the math here together. The PaO2 is less than 60, meaning they are hypoxemic. The PaCO2 is greater than 50, and the pH is less than 7.35, indicating acidemia. This exact combination perfectly defines an acute type 2 hypercapnic respiratory failure that needs immediate ventilatory support.
Restlessness first, cyanosis last. If you master that concept and your ABG numbers, you are absolutely going to crush this on test day. But beyond the exam, as you step onto the floor for your next clinical, ask yourself, if your patient suddenly gets agitated, will your very first instinct be to grab a sedative or a pulse oximeter? Because that answer could literally save a life. If this explainer made things click for you, make sure to subscribe. We are dropping one killer med-surg topic every single day until you pass the NCLEX. Keep studying, stay focused, and I'll see you in the next one.